Hello everyone, my name is Dr. Vernayev. This is the second part of chapter 1. In continuation, I would like to discuss how to deal with negative attitude about aging and what are responsibilities of geriatric nursing. We work with different specialties, and even those sitting in class have different expectations of their future role as a registered nurse. Some of you want to work in labor and delivery, some of you with pediatrics, and you are less interested, for example, in geriatric population. This is expected, but sometimes we deal with other healthcare providers who might have negative attitude and express this negative attitude. All this can interfere with quality of care that the patient might receive. So your goal is to recognize, first of all, this negative attitude and make a plan how to deal with this. In majority of cases, this is done through education. Even if you feel some negative attitude, make sure that you are able to recognize it and address appropriately. Sometimes it's done through reflective journal or in communication with your colleague. Remember that you have to listen to all patients, including elder adults. Sometimes you might have more time needed for communication, patience, empathy to achieve this. And we will talk a little bit about different myths about geriatric population and how to deal with this. For example, it is believed that baby boomers will retire soon, and they will consume all money and Medicare money that are available for the population. In reality, it's not true. People who were born between 1946 and 1964 are well educated, and they were growing during the era when people learn about benefits of proper nutrition, physical exercise, harmful effects of smoking, for example, and drinking, and in majority of they are not so sick, so they took care about their health and themselves. So this has to be taken into consideration. And the best is to prevent and manage chronic conditions and encourage level of functioning. This will decrease medical expenses. Factors such as poverty, lower educational level, language proficiency are socioeconomic characteristics that can also affect the quality of health in the future. But census data predicts gradual increase in educational level, and even you guys are at school right now. Living arrangements of older adults. Housing settings, 93% live in independent housing settings, not in nursing home, not in border care facility or assisted living. So pretty large amount of elderly people live outside of institutions. Now, let's talk about sandwich generation, formal and informal caregivers. We discussed it a little bit already in chapter 7, and skip generation household. I'm a representative of, I think, all three. I belong to sandwich generation. It means that I have to take care of my parents and of my children. So I'm like a piece of bacon in a garden. I'm an informal caregiver. I take care of my parents, but I'm not financially reimbursed for this. Who is formal caregiver is the one whom the government pays for his or her services. And skip generation household means when a child is taken care of by grandparents, while parents, for example, are at work. My parents were working while I was raised by my grandma. That's why I call it I am from skip generation household. If you would like to learn more information about elderly people in different countries besides the United States. You can look at the websites of United Nations, World Health Organization, and Census Bureau in the United States can provide about information about geriatric patients across the United States. There you can learn more about life expectancy in different countries, literacy rate, and per capita income. Also, let's talk about different myths and what happens in reality. For example, a person is considered old at the age of 65. Is it true? Not in reality. At 65, a person might feel very young. I had a very funny experience when I was about your age. My sister came from high school. She was a high school student. And she came, and the first thing that she told that, Marina, you are old. And the worst thing was not what she told me, that I believed her. I was frozen. I said, my God, I'm old. So it's not old by chronological age. It's also, do you remember about subjective, about perceived and functional age? This is supposed to be taken into consideration. By the age of 75, people are quite homogeneous as a group. No, unfortunately, you are not exposed to patients in elderly care centers because of COVID, but you would see how heterogeneous they are. And with different interests, different experiences, different chronic conditions, they are different. Families no longer care for the older adults. Do you remember that 93% live outside of institutions, in households, and they supported by family members? By the age of 70 years old, individual psychological growth is complete. No. Growth and educational level and ability to learn is not complete. It's just slower than with a younger individual. For an older adult, need more time for gaining new information. Health promotion efforts are not beneficial to those who are who have more chronic conditions. Is it true? Absolutely not. We still have to promote healthy lifestyles, diet, exercise, health screening, immunization, and the more we do it, the longer an elderly person might survive and be independent and in good functional health. As I told that the elderly people can learn complex new skills, but remember this task is slow. Constipation. It's not a part of old age. A younger person also might have constipation, but it depends about lifestyle, nutrition. Geriatric patient might have more predisposition by it, but again it's more about their lifestyle that are not so active as young. Skin wrinkles. I disagree that it is more related to age. Exposure to ultraviolet light and smoking are more predisposed to skin wrinkles. You can see younger individual who is a former smoker or current smoker, and you can see this person full of wrinkles. By the way, I use this for teaching, to help individuals to quit smoking, especially to work with females when I can explain that you will be more with wrinkles if you will continue to smoke. Sexually less active. It's not age, it's about health conditions and medications. For example, if blood supply is not sufficient to genitalia, this can be affected. Or some medications, for example, such as beta blocker, can decrease libido. Healthcare professionals readily recognize adverse medication effects. Unfortunately, not true. Review of medications that the patient is taking is not frequently done, and sometimes a patient takes more than necessary medication. Appropriate review of medication is required. So also about wellness nursing care for older adults. Nurses accept patients as a holistic as a whole in comparison to medical doctors, so keep in mind to assess body, mind, and spirit and how it's interrelated. What I tell my students, in majority of cases this is applicable. Exception is when you have an emergency, when you have to take care and have to do urgent interventions. In this case, mind and spirit are secondary and body is primary. Identify and challenge ageist attitude, including your own. This was already discussed. And take older adult as a whole, not as a disease that a person might or might not have. Always look at potential of an older adult, what this person can do. If a person can do self-feeding, allow him or her do this. You can finish feeding whatever is not finished and helping the person, but initially let, for example, a person to feed him or herself. Teach self-care behaviors. Always think about caregivers. A caregiver who burn out is the potential for violence and abuse. So make sure that this is also taken into consideration. And implement intervention to improve physical comfort, psychological and spiritual growth, especially for terminal patients who are on comfort measures only or hospice. And always work with social services. I deal with social workers in all skilled nursing facilities, and they are great help in terms of recommendations if necessary and referrals. This is the conclusion of chapter 1.